From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at Albert Einstein College of Medicine, Montefiore Medical Center, and Web Editor at JAMA Neurology. Today I'm joined by Dr. Julie Werenberg Dreier, and we're here to talk about her work with her and her colleagues on prenatal exposure to anti-seizure medications and incidence of childhood and adolescent-onset psychiatric disorders. Dr. Dreier is an epidemiologist and senior researcher for SCAN-AED at the National Center for Register-Based Research at the School of Business and Social Science in Aarhus University in Denmark. Dr. Dreier, welcome to the JAMA Neurology Author Interviews podcast. Thank you for joining us.
Thank you. It's a pleasure to be here.
I'm really excited by this work that you and your colleagues have done because prenatal exposure to these types of medications, anti-seizure medications, always has been a controversial topic. And looking at this angle in terms of childhood and adolescence onset psychiatric disorders as opposed to adult onset psychiatric disorders, I think is something that should be looked into more, and that's exactly what you're doing. Can you tell us about what we know currently? And if you've had previous work on this, I think you have a little bit on this topic and what you're looking to accomplish with this study.
Yeah, so it's been known for decades that anti-seizure medications can be teratogenic and increase the risk of congenital malformations. But it's only within maybe the last 10 to 15 years or so that we've come to realize that not only may prenatal exposure to these medications cause structural defects, but they may actually also be associated with functional defects. So, for instance, functional defects of the brain in terms of cognitive or behavioral or emotional functions. And by now, it's fairly well established that prenatal exposure to valproate is associated with an increased risk of neurodevelopmental disorders, such as autism spectrum disorder, intellectual disability, and impaired cognitive function. We also know that some of the other anti-seizure medications may negatively affect fetal growth and development, but our understanding of the link with psychiatric disorders in childhood is quite limited for the most of anti-seizure medications. And our knowledge is also limited to certain neurodevelopmental disorders such as autism, ADHD, and intellectual disability. But we don't really know whether any adverse behavioral effects of prenatal exposure to these medications is really limited to these endpoints. So with this study, we really wanted to systematically compare a wide range of different anti-seizure medications with respect to a broad spectrum of psychiatric disorders with onset in childhood and adolescence in a hypothesis-free manner. So this was really meant to be an explorative study.
Okay, yeah, that's key, defining this as an explorative study, because I think in terms of the methods and the design, it could be a little bit difficult kind of parsing things out and getting direct data and information without certain confounders. So to that effect, can you tell us about how the study was designed and the data collection and specifically what anti-seizure medications you were looking into?
Yeah. So this was designed as a cohort study, and it was carried out within this overall SCAN-AED project. And this is a study of anti-seizure medication teratogenicity, and it's based on children that are born in Denmark, Finland, Iceland, Norway, and Sweden in the period from 1996 to 2017. In SCAN-AED, we have really pulled and harmonized data from nationwide registers in each country and comprised a database of more than 4.5 million children. In this particular study, we restricted the analysis to the approximately 38,000 children that were born to mothers with epilepsy. Mm-hmm. And we then looked in the national prescription registers, and we used information from those to see whether the mother had redeemed any prescriptions for anti-seizure medications in the period from 30 days before the last menstrual period until birth of the child. And we analyzed all the most commonly used anti-seizure medications in our dataset, and that was valproate, lamotrigine, levetiracetam, carbamazepine, oxcarbazepine, topiramate, clonazepam, pregabalin, and gabapentin. And if the mother had only redeemed prescriptions for one type of anti-seizure medication in that period, we then considered it as monotherapy. If she had redeemed prescriptions for more than one type of anti-seizure medication in that period, we considered it as polytherapy, and then we just divided them into combinations with and without valproate. And in terms of the outcomes, we retrieved information on psychiatric disorders in the children from the patient registers, and they contain diagnostic information from inpatient admissions and outpatient visits in specialist care. And then on the basis of ICD-10 classification codes, we decided to look at 13 overall groups of psychiatric disorders, and they included substance use disorder, schizophrenia spectrum disorder, mood disorder, anxiety disorder, eating disorder, personality disorder, intellectual disability, autism spectrum disorder, other developmental disorders, and that included developmental disorders of speech, scholastic skills, and motor function, ADHD, oppositional defiant disorder or conduct disorder, attachment disorder, and then finally tic disorder.
Very comprehensive.
Yeah, indeed. And then in addition to each of these 13 psychiatric endpoints, we also defined a combined psychiatric endpoint, which was just if the child had any of these disorders. And then for the analysis, we were really interested in estimating both relative risk measures and absolute risk measures. And we did that for all combinations for each of the 12 exposure groups. So that was 9 monotherapies and 2 polytherapies, and then an overall any anti-seizure medication exposure group, and then 14 psychiatric endpoints. So it really sums up to nearly 170 combinations. So with this huge number of combinations, it's also quite clear why this is really an explorative study.
So in terms of the follow-up, because you looked at the charts were from 1996 to December 2017. So you were able to follow children from birth until age 15, age 18, up to 18 years old. Is that correct?
Yes. So it varied slightly depending on the countries. For Denmark and Finland, we had information all the way back to 1996. So these children, for those that were born in the early study period, we were actually able to follow them until age 22. But for some of the other countries, from Iceland and Sweden and Norway, we had them included from around 2005, 2006. So these children were younger, only up to 10 to 12 years of age. So that also means that in terms of analysis, looking at psychiatric disorders with onset mainly in adolescence, those analyses will be based mainly on the data from the Danish and Finnish cohorts.
Now, in terms of your results and what you found, tell us about, I'm very interested in valproate. Let's start with that first.
So for valproate, this study really strengthened the evidence for the warning that already is against the use of valproate in pregnancy. Going into the study, we already knew that prenatal exposure to valproate was associated with an increased risk of neurodevelopmental disorders, and this study really confirmed that. When we compared children of mothers with epilepsy who did not use anti-seizure medications in pregnancy to the children of mothers with epilepsy who used valproate, we found around a 2 to 3-fold increased risk of intellectual disability, autism spectrum disorder, other developmental disorders, and also ADHD. But something that I think was new in this study was that when we looked at the absolute risk of being diagnosed with a psychiatric disorder by the age of 18 years, it exceeded 40% for the children with prenatal valproate exposure. And many prior studies have estimated the risk of a single disorder. But this is really the first time we get an estimate of just how many of these children that will end up being diagnosed with a psychiatric disorder before reaching adulthood. And I think this is an alarmingly high proportion of these children.
And this is valproate monotherapy.
Yeah, it's monotherapy. For the estimate for valproate in combination with another anti-seizure medication, it was very similar in the same range.
All right, so it wasn't a higher number per se, like exacerbated by the presence of another agent.
No, it didn't. No. And I think some other novel findings regarding valproate that I think could be highlighted is that prenatal exposure to valproate was not associated with an increased risk for many of these later onset psychiatric disorders, such as anxiety disorder, or mood disorders, substance use disorder, or schizophrenia spectrum disorder. And this has not been shown or even looked at before. So I think this is also important.
Yeah, absolutely. I think so many decisions are being made during pregnancy about medications, especially individuals who have severe epilepsy. What do you have to say about that? Because I'm assuming the individuals in a study like this are those who may be suffering from severe epilepsy where they need to be on medications. There isn't another option for them. What do you think about that in terms of your results and being at the bedside and speaking with the patient?
Well, I think these results clearly show that for a drug such as valproate, it should be avoided if at all possible. It should really be the last option. And I think what this study is aiming at is also to provide some data on some of the other anti-seizure medications. So, what would be the best options if we cannot go with valproate? And this is something that has been lacking for many anti-seizure medications and also for many of the newer anti-seizure medications. Data is still limited because we don't have that long follow-up in the children yet to really discover the risks.
Now, you did look into, you told us about the other medicines that you looked into. So there were lamotrigine, carbamazepine, oxcarbazepine. You did topiramate, levetiracetam. Can you tell us about that?
Yeah, for topiramate, this study supports some of the rising concerns there are about the use of topiramate in pregnancy. We found that children with prenatal exposure to topiramate had an increased risk of ADHD, approximately twofold increased risk. And then we found some borderline significant associations with autism spectrum disorder and intellectual disability. And these findings are especially interesting and timely in the light of some recently triggered safety reviews that has been initiated by the UK Medicines and Healthcare Products Regulatory Agency and also EMA's Safety Committee, following the publication of the first SCAN-AD paper last year here in JAMA Neurology as well. So in our data set, we only had around 300 children with prenatal topiramate exposure. So, of course, there are still a lot of the psychiatric endpoints that we were not able to assess, especially for those psychiatric disorders with typical onset in adolescence or later. So, there is still a lot that we don't know. But for now, this study really supports the concerns about topiramate use in pregnancy. And then for lamotrigine and carbamazepine and oxcarbazepine, these were some of the medications where we had quite a lot of data. And the results reassuringly showed that they were not associated with long-term behavioral or developmental disorders across the entire spectrum of disorders. And of course, it is important to mention that in this study, we did not look into, for instance, timing of exposure or exposure dose. So we cannot rule out that there could be risk associated with exposure to these medications at higher doses or perhaps at sensitive timings in pregnancy. But overall, we did not find any risks. So for levetiracetam, this study provides some preliminary indication for caution with use in pregnancy. We found that children with prenatal exposure to levetiracetam had an approximately twofold increased risk of ADHD and anxiety disorder, and this is something that has not been reported before. But given that this is a single study showing this increased risk with prenatal levetiracetam exposure, we are still somewhat cautious in our interpretation of that finding. In this study, we carry out hundreds of analyses, which increase the risk of type 1 errors, meaning that finding an association that is not really a true association. So possibly this could just be a random finding. The other thing is that although we do adjust our analysis for many different potential confounders, we cannot entirely exclude that there could be some residual confounding, for instance, by lifestyle factors or maternal psychiatric disease, which are some of the things that the registers does not always capture perfectly. And of course, it could also be that this is really a true signal. And certainly, I think these findings should give rise to further research looking into this to see whether this could be replicated in other cohorts.
Oh, that's very good. I mean, with this explorative study, we're, like you said, seeing which medicines would be great options for individuals. And I think the dosing is that was going to be my next question in terms of deciding what will manage the epilepsy, but also what is a dose that can lead to further risk. And I think sounds like a future study based off of this baseline explorative paper that you all engaged in.
Yes, we did not look into that because we had so many combinations, these 170 combinations. Just adding one analysis of those would then lead to 170 new analysis.
Exactly, right.
And the thing is that in observational studies where we use the registries like we've done in this study, it is extremely difficult to accurately estimate the dose of medications used in pregnancy because we don't know exactly which dose that has been prescribed. The only thing that we can see is that whether the mother redeems the prescriptions. We don't even know if she takes the medication. Of course, this is the assumption that we made, but in terms of dose estimation, it always becomes relatively crude. So this is something that when we do it in studies, and sometimes we do, it really deserves a lot of thought on how to best make these estimations given the data that we have.
Thank you so much, Dr. Dreier. This is very informative and helpful, and I think I'm definitely looking forward to future work on this topic to help guide us clinicians on managing our patients and discussing future expectations.
Well, thank you for having me, and I want to thank all of the ScanAD collaborators from Norway, Sweden, Finland, Iceland, and Denmark who contributed to this work.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. Julie Werenberg Dreier about prenatal anti-seizure medication use and incidence of childhood and adolescent onset psychiatric disorders. You can find the link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.